Good afternoon and good morning, our European Society of Cardiology. We are very much pleased and privileged to be part of one of the affiliated societies of European Society of Cardiology. We officially got affiliated this year. Thank you very much, and we are very much pleased and privileged. So this symposium will be a collaboration symposium on chronic coronary syndrome. And we have got, there are 3 topics will be done by eminent cardiologists. The first topic will be the non-invasive diagnostic workup for chronic coronary syndrome, current state of the art, by Professor Antti Saraste. And the second topic will be reversation in chronic coronary syndrome, who, when, and how, by Professor Jose Lopez Zendon. And the third topic will be coronary artery disease, angina due to microvascular dysfunction, importance, diagnosis, and treatment. So shall we move to the first session? I hand over the mic to Dr. Shantaraj.
Professor Antti Saraste is a cardiologist, scientific director of IDIPA's Research Institute, Professor Cardiology, University Autonomia de Madrid, Spain, Professor of Cardiology, Department of Clinical Medicine, University of Turku, Finland. He is going to speak on the non-invasive diagnostic workup for chronic coronary syndromes, current state of the art. Professor Antti Saraste. Over to you. Can you hear us, professors?
Yes, thank you very much for the possibility to present here. We had some technical problems at the beginning, but I think we go so that I try to share my screen.
Screen share. Yes, now we can see your screening.
Oh, great. Thank you very much for the possibility to present on diagnostic workup of chronic coronary syndromes. Here are my disclosures. I will talk mainly based on the current European Society of Cardiology guidelines for diagnosis and management of chronic coronary syndromes, and I will focus on things that have changed or are changing currently. One thing that has changed in evaluation of patients with chest pain is that prevalence of obstructive coronary artery disease has decreased over time. These bars here demonstrate frequency of obstructive coronary artery disease in men and women of different ages and with different types of chest pain. The highest frequency is in males, elderly men with typical angina, and lowest in young women with non-anginal chest pain. The blue bars demonstrate frequency in previous analyses that formed the basis for pretest likelihood tables in the previous version of the guideline. Brown bars demonstrate frequency in very recent analysis of contemporary study cohorts, including 16,000 patients with chest pain. And we can see that in all groups, frequency of obstructive disease has decreased considerably. Actually, prevalence is only 1/3 of that in the previous analysis. And this has implications for evaluation of patients. This is a table showing pretest probability of coronary artery disease based on age, sex, and type of symptom. Table also includes dyspnea, which is associated with very similar pretest likelihood as compared to atypical angina. In patients with very low pretest probability, less than 5%, it is reasonable to defer diagnostic tests. Diagnostic tests perform best and are most useful in those patients with increased pretest probability, which is more than 15%. In addition to age, sex, and type of symptoms, there are other factors that modify pretest likelihood. Risk factors for cardiovascular disease, resting ECG changes, left ventricle dysfunction, suggestive of ischemia, abnormal exercise ECG, and coronary calcium by CT scanning, they increase likelihood of obstructive disease. And actually all these should be incorporated in the overall assessment of clinical likelihood of obstructive coronary disease. But how much risk factors contribute actually? It's difficult to study because it requires very large patient cohorts. This is a recent study from Denmark with more than 40,000 patients who have undergone coronary CT angiography due to suspected obstructive coronary disease. And this table again presents likelihood of obstructive disease according to age, sex, and type of symptom. In addition to this, this includes information about impact of risk factors. These include family history, smoking, dyslipidemia, hypertension, and diabetes. Each one of these contributes roughly equally to frequency of obstructive disease, so they have been combined as numbers of risk factors, 0 or 1, 2 or 3, or 4 or 5. We can see that in patients with relatively low pretest likelihood, risk factors contribute significantly. For example, in young man with atypical chest pain, the likelihood of obstructive disease is 4 times higher if there are 4 or 5 risk factors as compared to those with no risk factors. In patients with typical angina and high pretest likelihood, impact of risk factors is less significant. In addition to providing information about risk of cardiovascular events, coronary artery calcium also provides information about likelihood of obstructive disease. High coronary calcium score is associated with increased likelihood of obstructive disease. Calcium score of 0 is associated with lower than expected pretest likelihood. Calcium score is relatively infrequently used for determining likelihood of obstructive disease, but it's good to note that many patients have CT scan of the chest area for other reasons. Strength of clinical evaluation of likelihood of obstructive disease is that it has relatively or very high negative predictive value, especially for ruling out prognostically significant coronary artery disease. This graph demonstrates main diagnostic pathways in those patients in whom diagnostic testing is considered useful. One option is to use coronary CT angiography. It is particularly useful for excluding obstructive coronary disease in patients with relatively low clinical likelihood and no previous history of coronary artery disease. Another option is non-invasive testing for myocardial ischemia. Information about ischemia is very important for decisions on doing myocardial revascularization. Therefore, ischemia testing is most useful in patients with higher clinical likelihood and if viability assessment is also required. Some patients can be referred directly to invasive coronary angiography, and this is reasonable in patients with high clinical likelihood and severe symptoms despite medication, and also in patients who have high-risk features on initial clinical evaluation, for example, left ventricular dysfunction suggestive of myocardial ischemia. Coronary CT angiography is a relatively new diagnostic technique. We can obtain very high-quality images of coronary arteries after injection of intravenous contrast agent. And this is very useful for detecting coronary atherosclerosis and also obstructive coronary artery disease. This is one example of stenosis in the proximal left anterior descending coronary artery. Looks very similar in the CT angiography image and in the invasive angiography image. This is a meta-analysis comparing diagnostic accuracy of different diagnostic tests for obstructive coronary disease. We can see that the strength of coronary CT angiography is that it has very high sensitivity for detecting obstructive disease. In other words, it's good for excluding coronary artery disease. Specificity is lower, about 80% for detection of anatomical stenosis, and in studies that have used functional endpoint, reduced fractional flow reserve, specificity is relatively low, 50 to 60%. That is related to many things like the degree of stenosis is a relatively weak predictor of ischemia, and then calcification and artifacts can make image analysis challenging. European guideline recommends that either coronary CT angiography or non-invasive functional imaging for myocardial ischemia are recommended as the initial test to diagnose coronary artery disease in symptomatic patients. It's important to realize that coronary CT angiography shows both obstructive and non-obstructive coronary artery disease. On the left, I have an example of non-obstructive calcified plaque. On functional test, there is no ischemia, or the result of functional test would be actually normal in this case. On the right, I have very severe obstructive coronary stenosis that is most likely associated with myocardial ischemia. And in the middle, I have large atherosclerotic plaque causing intermediate stenosis that may or may not be associated with myocardial ischemia. Patient selection is very important for successful use of coronary CT angiography. Extensive calcifications, for example, in elderly patients or patients with high clinical likelihood, make evaluation of stenosis very challenging. This is one example of extensive calcification in the proximal LAD, but only very little narrowing in invasive coronary angiography. Irregular rhythm may cause motion artifacts that make interpretation of images very difficult. Stents and other metal objects cause artifacts that also make evaluation of stenosis challenging. So coronary CT angiography is not recommended in conditions that make obtaining good image quality unlikely. Functional tests, for example, myocardial perfusion imaging, is associated with higher specificity for detecting functionally significant stenosis or myocardial ischemia. Therefore, these are recommended if coronary CT angiography has shown coronary artery disease of uncertain functional significance or is non-diagnostic. This is an example of SPECT imaging, which is one of the most commonly used functional imaging tests. It provides actually a lot of information. In gated images, we can see that the patient has reduced left ventricle ejection fraction. On rest image, we see a perfusion defect in the apex consistent with previous myocardial infarction. And on stress images, we see that there is reversible perfusion defect in the anterior wall consistent with stenosis in the left anterior descending coronary artery. Stress echocardiography is another very commonly used imaging test for myocardial ischemia. This is one example of patient with an ischemic wall motion abnormality in the apex during peak dobutamine stress. At rest, contractile function is normal. One approach to anatomical and functional evaluation of coronary artery disease is hybrid imaging. In our center, we do all coronary CT angiographies with a hybrid PET CT scanner. In the presence of suspected obstructive stenosis, we can immediately do myocardial perfusion imaging with PET. And in this case, a hybrid image shows 3D reconstruction of coronary anatomy. There is stenosis in the proximal LAD, and on green color, we see that myocardial perfusion is reduced in the area of left anterior descending coronary artery, indicating that there is functionally significant stenosis. In addition to making a diagnosis, diagnostic tests provide information on prognosis of patients. that should be used to guide therapy to improve outcomes of patients. One of the strongest prognostic factors is the presence of left ventricular dysfunction in a patient with chronic coronary syndrome. Therefore, rest echocardiography is recommended in all patients with suspected coronary artery disease to quantify left ventricle function. In patients with borderline left ventricle ejection fraction, systolic strain can be useful because it's a very sensitive marker of systolic dysfunction. This is one example of a patient with ejection fraction of 40%, but very severely reduced global longitudinal strain. And the strain map also shows that there is regional wall motion abnormality in the anterior wall, consistent with severe stenosis in the LAD in this patient. Large area of myocardial ischemia and extensive epicardial obstructive disease, three-vessel disease with proximal stenosis, left main disease, and disease in the LAD, proximal LAD, are well-known risk markers based on imaging diagnostic tests. But what about outcomes after non-invasive testing? This is the Scott-Hart trial that randomized 4,000 patients with chest pain to either standard evaluation, mainly with exercise ECG, or coronary CT angiography on top of standard evaluation with exercise ECG. After 5 years of follow-up, there was a significant reduction in the number of non-fatal myocardial infarctions in those patients who had coronary CT angiography as the first diagnostic modality on top of exercise ECG. What are the potential reasons for this? There was no difference in the use of invasive coronary angiography or rate of myocardial revascularization between groups. However, there was a difference in the use of preventive medications. Those patients who had coronary CT angiography had more often antiplatelet therapy and statin therapy. So detection of extensive non-obstructive coronary atherosclerosis or obstructive coronary disease by CT angiography provides an opportunity to intensify preventive medications. This is another very recent study in which some of the patients referred for invasive coronary angiography were randomized to coronary CT angiography instead of invasive coronary angiography. After 4 years of follow-up, there was no difference in rate of cardiovascular death, myocardial infarction, or stroke, indicating that coronary CT angiography is a safe test as the first initial diagnostic test, also instead of invasive coronary angiography. What about the role of exercise ECG? Exercise ECG is very useful for assessment of exercise capacity and any potential symptoms related to exercise. It also provides information on event risk. There are well-known markers of high event risk, chest pain and ischemic changes on low workload, extensive ST depression, ventricular arrhythmias, and abnormal blood pressure response. However, the diagnostic accuracy of stress ECG is clearly inferior to that of imaging diagnostic tests. Therefore, the recent guideline indicates that exercise ECG may be considered as an alternative test for diagnosis when non-invasive imaging is not available, but the possibility for false positive or false negative result must be taken into consideration. So to summarize, prevalence of obstructive coronary disease is lower than earlier among patients who are evaluated for chest pain. Either coronary CT angiography or non-invasive ischemia testing are recommended as initial non-invasive tests for diagnosing obstructive coronary artery disease. CT angiography preferably in patients with low clinical likelihood, and ischemia testing in patients with higher clinical likelihood. Exercise ECG is very useful for clarification of symptoms and assessment of event risk. And risk assessment, including evaluation of left ventricle function, is very important in all patients with suspected coronary disease. So thank you very much for your attention.
Professor Sarasti. Please be with us till the other two lectures is over for answer any questions, end of it. I hope you can do that. And we'll go to the other lecture, please.